All right, everybody, welcome to the Colloquium. We're excited to have Meghan O'Neil here. She's currently a postdoctoral scholar in the Drug Enforcement Policy Center here at OSU. But she actually lives like 3 hours away. It's the drive-in this morning. Got stuck in all the traffic. She actually has her PhD from SUNY Albany in sociology from 2018. Then she worked from 2018 to 2023 at the University of Michigan on an NSF-funded grant where she was working with both legal scholars as well as sociologists. Does a lot of work on inequality, both criminal justice outcomes, as well as health and housing. I just heard on your bio that you got an assistant professor job at Michigan State. Is that right? Congratulations. Michigan State. We're super excited to have her here. So I'll turn it over to you, Meghan. Thanks for having me.
How's everybody doing today? Better after the pizza, right? Happy to be out here and discuss the research I've been working on for the past few years. Started at Michigan, and we are still conducting analyses at Michigan with a follow-up up to 10 years. So I'm excited to share both some preliminary findings as well as talk about our recent methods and why I'm excited about that as a postdoc going into assistant. But the title of the talk today is Opioids, Housing Insecurity, and Health Disparities among Justice System Involved Patients in Community-Based Treatment Centers. So the reason why I think this is an important, broadly important study for policy work is we're thinking about crime and we're thinking about health and the intersections and how this might impact scholars more broadly in the space of the American economy, public health, and so thinking about risks surrounding drug use and how that can impact the local and broader economy, as well as the health surrounding our local community and thinking about the overdose crisis nationally. So even if you have no interest in drugs whatsoever, you can think about it from a lot of different angles. And here I'm also going to tie in today the housing aspect for scholars who are interested in housing and how that pertains and relates to the overdose crisis. And thinking about the costs associated with crime and individuals who are coming through the justice system, how that can impact the local economy and the national economy. And I'll get into that. So I go through, I have an outline basically to give you a summary of a much broader study and sort of narrowed it and focus on what we'll talk about today. Some of the things that I think are helpful to share, especially with grad students, are looking at things like the partnerships that sort of lay the foundation for this study and why I think that's valuable and helpful, especially for policy-focused scholarship. I talk a little bit about my funding, how I was able to collaborate with others to obtain funding and what our goals are for the future. Material methods, of course, results, conclusion, next steps, so pretty standard. So the primary research question that I'm trying to answer is, do justice system involvement significantly relate to health risks for this population? And when I say justice system involvement, I'm in a much broader justice system involvement than the typical criminal justice misdemeanor felony cases. I'm thinking about family courts, family dissolution, so child support, divorce, things that pertain to housing. So you think of in the civil courts like foreclosure, bankruptcy, citations related to homelessness, as well as eviction proceedings. So I'm thinking about a much broader scope of how the individuals in our study actually come in contact with the justice system over the course of their lifestyle, of their life. And do these justice system involvements and these past experiences of justice system involvement relate to their health risks and their health risk behaviors? And I'm particularly focused on health risks related to premature mortality, tying in the overdose crisis with the premature mortality that is related. Sorry about that. That was just a pause to see if you're paying attention. Is that how it's supposed to look? Rebecca?
Yeah, it works, yeah.
Okay,
You want it fuller screen?
sure. Thank you. Okay, no, it's fine, it's totally fine, yeah. Yeah. Thank you. Okay, I'm not gonna press that button and test it. Rebecca, I apologize, I said that I would be unmuting your help, but it's not playing at all. It's a screen sharing. No, it doesn't. That's fine, okay, yeah,
Because that seems to work.
all right, we're gonna scrap this all together, so I don't lose anybody out there. Okay, back to it, thank you for your patience. So do justice system involved relate to health risks for this population? So what sorts of questions are we asking? What sorts of variables are we testing? Like I said, we're looking at both the criminal justice involvements of people who use drugs, as well as the civil justice involvements, everything from family courts to housing proceedings. And we're looking specifically at 4 health risk outcomes. We're looking at opioid use, overdose, polysubstance use, and multiple treatment admissions. And we select these because they're known in the literatures to be related to premature mortality. And who are we speaking to? We have a representative sample of non-incarcerated people who use drugs in Southeast Michigan, specifically from uninsured and Medicaid population. And these are not folks who are tied to, these are all civilians. They're not receiving treatment with the VA. So those folks we don't have in the sample, but we do have a really nice sampling of that is representative. So we can draw some conclusions based upon this population, which we're excited about. And the 2 treatment centers where we collect our participant sample from engage in some harm reduction measures, which I know are important to some policy focused scholars these days. So they use overdose education. All of the rooms in the treatment centers have naloxone, and naloxone is distributed to all the clients. Peer recovery sports, many of the staff at the treatment center where we collect our participant enrollments are trained peer recovery sports, so they have themselves been through the addiction cycle and are now in recovery from addiction and provide peer recovery. They offer HIV testing and education, client goal setting, and also street outreach. So if you think about folks who may see panhandling, in those sorts of circumstances where someone is out in public and behaving in a manner that appears to the police that they may require some sort of intervention, clinical intervention. We do have street outreach team members at the treatment centers who will go and bring those individuals into treatment if they're willing and divert them from the carceral state. So getting further into the partnerships. We have both criminal justice, civil justice, and community-based partners. And this partnership aspect is very, very important to this study because without these partnerships, we would have no sample. So what's really interesting about our sample is we have a very hard to reach population. So we have 70% of the participants in our study have been homeless. So it's a very difficult to reach population. We also have an overrepresentation, which is a natural sampling of Native American and African American people who use drugs. So both of those are high-risk populations that often are undercounted in traditional administrative data sets. So we are very lucky to have collaborated with local treatment centers to engage the population that we have in our study. And we were able to secure a partnership with an organization called the Community Mental Health Partnership for Southeast Michigan. And we also work with the child support, the local civil justice child support agency, 6 criminal courts, 2 rehabilitative centers that have over 180 transitional housing beds as well. And then we did secure a partnership with the Washington County Jail to work with folks in their treatment program. Due to COVID, we had to pivot away from that population because we were not able to go into the jail during the participant enrollments for this. So why do we care about the community partnerships? So I touched on that a little bit, but I want to emphasize how valuable it was to actually get access to this vulnerable population who otherwise may be sort of unable to reach, particularly because these are not folks who would traditionally complete a letter survey that they receive in the mail, for example, or they may not regularly monitor email. And so reaching them via survey on, via email with a survey is not something that's, very likely to result in any sort of representative sample. So through the Community Mental Health Partnership for Southeast Michigan, we utilized their case management system called Cricket, and we were able to collect a representative sample of everyone between December 2021 and July of 2023 who were coming through their treatment centers and offer those individuals the opportunity to participate in our study. And from there was some random assignment for our broader study. But for the focus of this talk, I'll just discuss the specific research questions that I described already. And if anybody has any questions about the broader randomized control trial, then I'm happy to touch on that. And so the random assignment, I would just say, I think is pretty interesting. We're able to use an algorithm that's like a coin flip to conduct the random assignment through the Community Mental Health Partnership for Southeast Michigan. And so that's what enabled us to create fully random sampling in terms of who is entered into our treatment and experimental and control groups. So we work with some other valuable treatment partners. We work with sobriety court, we work with drug court. They collaborated with us, hoping that this study would provide some novel feedback so that they can then go to their municipalities, into the state, into the feds, and ask for funding because they are overwhelmed with demand for treatment court staff to basically process all of the people who are asking for help. So treatment courts, drug treatment court and sobriety court divert individuals away from incarceration and through a monitored 2-year program with supportive services in the community as well as judicial oversight. And so they're under sort of a very comprehensive supportive system for a 2-year period. And if they complete that 2-year period, whatever sentence was over their head sort of disappears, right? And then they can go back to their communities and back to the economy, back to their families. And so the drug and sobriety courts are really pivotal to getting past the criminal justice issues that are facing a lot of these individuals. And also throughout the treatment court 2-year period, they will receive supportive services that can help them to overcome the civil justice, the housing issues. For example, they might get placed into transitional housing or receive some sort of a scholarship to help on a down payment for an apartment, for example. And the treatment courts we work with, one of them in particular waived the $50 warrant fee for individuals who were participating in our study to clear criminal warrants. And so that became now 0 cost for the defendants. And so having these community partnerships helps not only to collect the data, but also to have, modest improvements in the process. As we identified issues with the current criminal justice process, having created their own barriers for individuals who were indigent coming through the system. And we allowed through our study, the opportunity to provide online resolution for the individuals who were receiving treatment and enrolled in our study. We had half of the individuals were assigned to a free online legal tutorial to help manage their case issues, whether that was a child support case, an eviction case, for instance, or a certain misdemeanors could be resolved as well online. So these are some of the resources that came about through the randomized controlled trial broader study. And sometimes students will ask, how did you create these partnerships? This sounds interesting. I'd like to do something like this. Can you tell me about the process? I can tell you it was multifaceted. I asked for a lot of help. I often reached out sort of cold calling the way you would in marketing and sales, and reaching out to the stakeholders in the community. When I found out, this treatment court would be an excellent source for support for this study, I would reach out directly with whoever managed the treatment court and tell them about what our goals were of the study and how the analysis from this research might be able to provide information to their group in a way that would be helpful for their own goals, whether that be to, for instance, obtain a better understanding of how many of their clients require housing when they come through the treatment court, for instance. And so I sort of reached out directly to a lot of folks, and also went into the spaces where these criminal and civil cases would unfold, and sort of introduce myself in that manner, doing a bit of ethnography. I participated in like the sobriety court softball game, things that were sort of informal, and would just sort of get my face out there to people in the community to know that I appreciate the work that they're doing, and explain what I'm trying to do, and sort of build that trust over time. We also conducted focus groups. A student conducted focus groups both with people who use drugs, people who formerly use drugs, folks who work at the treatment centers, asking them, what sorts of questions should we include in our life course history surveys that are part of our participant enrollments. And we received excellent feedback from people who use drugs about what sort of needs they felt were not being met by the current criminal civil justice practices, where there were gaps, and what sorts of things they would like to be heard on, whether that had to do with job placement, for instance, or housing, and housing was a big one. We also conducted a focus group at there's quarterly judges meetings for the county, and we went there and asked the judges what they would like to see as well, and asked for that sort of buy-in into the research to be supportive. And I had a lot of wonderful students who worked on this project over the past 5 years, in sort of every discipline, from sociology to pre-law, social work, economics. We had some folks who were in the military. We had folks who were formerly involved with the sheriff's department. We had a lot of people with lived experience who came forward and said, this is my past, and I feel like I can bring something to this research team. And I found that to be extremely helpful in terms of really fine-tuning our scientific research instruments, like our interview and survey research instruments. So really having a diverse set of minds of folks with both lived experience as well as practice experience. So we had some folks who worked directly in the treatment centers, who had years of experience. We were able to bring that all together to help improve the research. And our funding initially started out as a student project that I saw advertised at University of Michigan. I was a visiting PhD student at the time and thinking about doing a postdoc. And I was working as a pre-doc RA with the law school on some really interesting research surrounding using online courts. And this was in 2018, pre-pandemic, before really anything was online for courts. Everything was largely, you had to go to the courthouse, even if you received a ticket, you generally had to go into the courthouse if you wanted to dispute that. And so there's a law professor at Michigan Law, JJ Prescott, who founded a tech startup right there in Ann Arbor. And that tech startup provided an opportunity for a lot of legal issues to be managed online. And so I was interested in studying what that meant for the justice system and what that meant really for vulnerable populations who could really use a free, it's sort of a low barrier and low entry space to resolve their legal issues, which are often made a lot more complicated by the justice system as it stands. And so being able to sort of rectify a criminal justice warrant online seemed like obviously this is an obvious solution. Let's try it, let's test it, let's see what this can do for people, and is it doable, and what else do we need to do to make sure this reaches the people who need it most. Because these are folks who really can't afford counsel, cannot afford attorneys, especially for cases where you may or may not realize for civil justice, you do not have a constitutional right to an attorney to civil justice. So a divorce, an eviction, family dissolution surrounding child support, you don't receive an attorney. So if you don't know how to navigate the justice system, this can become a very large obstacle, a very large barrier that, especially if it involves children, could be something that follows you around for 18 years. So with these online court tools, I spoke to my mentor at the law school and asked if he would support me targeting these online court tools directly to vulnerable people in treatment centers. And that's where the idea for this project came together. With that first student service pitch, we were competing with students from the medical school and from engineering to do some sort of innovative research that would be for the public good. And so really, there had never been anybody from the law school who had tried to get involved in this sort of public service pitch, but I'm sort of somebody who doesn't really see things like that as an obstacle. And I asked if we were allowed to participate, and they said, sure, why not? So we tried it and we won, which was really cool. So like I think they selected 3 or 5 overall winners, and then we won the judges' choice, and it was a student and faculty panel on the judges. So we received like a really tiny award that summer. But what it meant, it was more symbolic, and it was like, okay, now we have feedback that this idea is a good idea, and let's roll with it and see what we can do. And from there, we went on to receive a larger $60,000 internal award at Michigan, which was called M-Cube, and it was like you had to take 3 faculty from different departments across the university who all bought into the research and said, I think this is a good idea. Let's come together. And then we competed and received this $60,000. And that was great startup money to pay students, pay for some other research funds required to then work on a federal grant in which I was able to obtain from the National Science Foundation, which is really exciting because I was still a student when I started. And then I had just graduated, applied, and right at the beginning of the pandemic, we received notice that we would get this award. So it was kind of interesting because we were ahead of the game in terms of thinking that online courts would be valuable, but we could never have predicted that we would actually start testing this during a pandemic when online courts not only were interesting, but they were the only way to sort of go about legal issues. So I'll stop there on that. You can see there's a couple of other awards that have come through since, which is great. And what did we do with all this funding? Well, we were able to pay competitive student wages. I was at the Institute for Social Research, so I was able to pay really great wages to my grad students, which was important. A lot of the students who I recruited, I self-identified, like I said, as having lived experience. A lot of folks identified as being first gen in their family to go to college. And so having a good wage was really helpful and incentivized people to do good work. We were able to fund travel for both myself and students to present this work across the country. And that was really exciting to be able to take students with me because I wasn't a tenured faculty member. You know, I was a research investigator and I was able to sort of fund this lab to support students as well. So that was exciting. We paid for incentives. So every participant in our study was paid $30 to sit with us and speak about their experiences. We provided hosting. And so like, what is hosting? It's kind of like what you have here, you know, pizza and drinks. But we were going into the treatment centers and bringing locally made donuts and really good coffee, like the best coffee around Southeast Michigan. And so people were really happy to see that. And that may sound very minor, and it is, but it's also more than that because a lot of the folks who are in acute treatment for addiction are really not permitted coffee at the time because they are clearing out their system of any sort of addictive substances, of which coffee is one thing that's often like a no-no. But the clinics allowed us to bring coffee in. So it's sort of like a perk, like a little incentive, a little pick-me-up for people who otherwise were in a really regimented experience. So they were happy to see us when we had good coffee. We paid for funding for data collection from the treatment centers. So I was really happy to be able to provide funding. They're always understaffed and struggling to operate. And we paid faculty expert stipends. We paid for hardware and software when needed, and equipment for persons with lived experiences to contribute. So the material and methods, everyone in our sample is an adult. They're receiving acute addiction services coming through that case management system, Cricket, and they had to have been receiving Medicaid or uninsured, like means tested to be entered into the Cricket system. And there were 401 participants. And when we sat with the participants in the treatment centers in a private room and enrolled them in the study, we offered them to complete a life course history survey. And rather than ask the questions in an interview format, which could be a little bit stigmatizing with questions about HIV status, drug use, criminal justice history, finances, we decided to have people sit in the room. We were in the room in case they had questions, but they did a self-guided survey. So they were able to have a little modicum of privacy as they responded to all the questions. And there were some open-ended answers where they could provide more details, sort of similar to an interview. And then we had some traditionally vetted survey metrics like the ACEs, Adverse Childhood Experiences survey. And we also administered the Kessler survey, which is a behavioral health survey. And depending on the individual, it took between 30 and 90 minutes. Some people like to talk in the sense that they provide really in-depth responses, and some people are pretty short in their responses. And they really provided a lot on their trajectories, transitions, and turning points. So if you are familiar with the life course history scholarship in criminal justice and sociology, that's a lot of what we were looking at here. So we had access to this Medicaid and uninsured case management system simply to identify, for the treatment centers to be able to identify who should be asked to participate in the study. And from there, the individuals were provided a release of information that said, yes, we would like to speak to Dr. O'Neil or the research team to learn more about the study. So before they could even basically talk to us, they were provided an opportunity to say, no, I don't want to participate, or I do want to participate, because their role as a treatment center client is privileged. So this is very privileged information. And so we tried to be very respectful of their rights and their anonymity. And then we had a much longer consent form. I think it was 9 pages. So things are IRB, but we had everything in there, and they were able to better understand what we would be doing and determine if they'd like to participate. And we went on weekly visits to the treatment centers over the course of 2 years for these enrollments. Unless there was a COVID issue, which did happen several times where we did not go to the treatment centers for public health reasons. And like I mentioned, people received $30, some coffee and donuts. And we did provide accessible services upon request. And we offered the survey in Spanish and English, although no one took us up, which is really interesting and something we're keeping in mind for future research and specifically in that region. We had technology assistance for anyone who didn't feel comfortable completing the survey online, and there were several people. And we offered literacy support. So our reading level, I think, was 6th grade or so for our survey, but some people were not able to read that, and it wasn't always like what you would think of as a literacy issue. Yes, there were literacy issues, but there were also issues about coming through the criminal and civil justice systems and being impoverished, where, for instance, on more than one occasion, a client told me that they didn't have their glasses. Like they had been staying outside for a while and they just don't have they can't read without their glasses, and they haven't had their glasses in a while, or their glasses are broken. And so in those cases, you think about like, without us there to guide them, we would have never had a response from that individual in this circumstance, right? And so that's why I'm really happy about getting to this population in the way that we did. We try to make it as accessible as possible. Our analyses included logistic regression. We put together some predicted probability figures, 95% confidence intervals. I'd like to credit my co-authors on the study, Dr. Rebecca Johnson at Georgetown, and Dr. David Cordova at Michigan, and Dr. Deborah Pinels. So again, it's a very interdisciplinary team. Rebecca's a sociologist, Dave is a social worker, Deborah is a psychiatrist, and then we had 2 excellent students who co-authored with us on this work, Mina Kim and Charlie Nugent. And we looked at the transitions. We tested arrest history, how many misdemeanors the individual had, felonies. We looked at homelessness, eviction, and bankruptcy, legal debts, and we included more than, like Alexis Harris looks at criminal legal debts, LFOs, and we included a bit of a broader scope on legal debts simply because this population had an extraordinary amount, a broad range of sorts of legal debts based upon their history with drug use over the years. So we get more into that in the paper, and we look at foreclosure, bankruptcy, and child support obligations. And then the health risks that are the outcome dependent variables, opioid use, overdose, polysubstance use, and multiple treatment admissions. The most common income that was reported was under $10,000, which is not surprising for this population. We had a good number of underrepresented African American folks and American Indian. We did not have enough Hispanic people who are self-reporting as Hispanic, so we do not think that is a robust coefficient to consider in our analyses. We had mostly men, about 70% of our population was male, which is in line with the broader criminal justice relationships of men and women who use drugs. We had just 1% non-binary. We had many people who were parents, and the average age of the person in our study was, the participants in our study was 40 years old. And this is a pretty educated population, higher than was anticipated. And I think that has to do with the fact that we are in, many of these treatment locations are in Ann Arbor and Ypsilanti, which, if you know anything about broader levels of education nationally, that happens to be like one of the most educated cities in the country. So that probably threw us off a bit. So we have a lot of folks who have gone to college, even though they are receiving Medicaid and otherwise lower income or disadvantaged. We had pretty high rates of eviction. About 40% of our population have been evicted at least one time. Foreclosure was 6%. We had high rates of foster care history, so much higher than the average, relative to the American population broadly. So we had almost 5% of folks who had been in foster care. A lot of people had a child support obligation as we measured it, meaning that they owed money to someone else for child support. So it's about 40% of our population. And then an outstanding legal debt was about 64%. So just over 6 out of 10 folks were aware that they believe that they had a legal debt. It's possible other people may have, but we're not. There were some folks who said, I just don't know. I don't know what I know. And about 1 in 4 folks said that they expected their legal debts to interfere with their ability to complete drug or alcohol treatment. And so that was really interesting. That's something from a policy lens that is important. And so why might, thinking about the literature, why might legal debt interfere with someone's ability to complete addiction treatment? And that has a lot to do with warrants and arrest warrants and bench warrants. And if individuals are coming here to treatment and have an outstanding arrest warrant that becomes known to the treatment center, because they are publicly funded, they're not supposed to have the person there without resolving their arrest warrants. So that becomes an issue, and a lot of people do leave treatment to go to jail, which is unfortunate because the treatment in jail is, if available, is not as effective according to most, if not all studies, as it is residential treatment outside of a carceral state. We had really high ACE scores, so some folks had all the way up to a 10. If you're familiar with adverse childhood experiences and childhood trauma, the higher the ACE score, the more likely you are to have poor public health outcomes as an adult. And so we had higher rates of high scores than across the country nationally, which is not unexpected. And we plan to do some subsequent pages looking at how those scores relate to other health outcomes that haven't been published already. And we had really high rates of people reporting polysubstance use, of having more than one substance of choice that they enjoyed. And that's one limitation of our study, is how we measured polysubstance use, had to do with specific questions surrounding preferences towards different substances, but that's not necessarily a polysubstance use diagnosis from a diagnostic criteria. So we will match that with diagnoses later on when we review clinical records for our follow-up data. We had about half of our population had overdosed previously, so it's really interesting. It's a pretty high rate, and you can expect that anyone who overdosed and died would not have been in the study. So the rates of people generally at 40 years old who've experienced overdose, if you include the people who passed away, would be higher, but 50% is still quite high. And looking at our outcomes, we found that controlling for measuring criminal justice interactions for individuals, civil concerns remained highly significant, such that homelessness was a predictor of opioid use above and beyond any criminal justice issues. So people who had felonies and misdemeanors but had been homeless were significantly 11% more likely to use opioids relative to people who had not experienced homelessness, who also had criminal justice issues. Eviction, folks who had been evicted were 18% more likely to use opioids. So we're seeing really interesting novel relationships here. Arrest history, felonies and misdemeanors in their history was definitely something that was predictive of correlated with opioid use. We found that African American clients in our sample were about 20% less likely to report opioid use relative to non-Hispanic white folks in our study. And for overdose, again, we find that housing insecurity metrics were correlated with overdose above and beyond criminal justice issues. So homelessness, about 19% more likely. So the individuals who had experienced homelessness were 19% more likely to have also overdosed relative to their peers who were not homeless. For those who had been evicted, they were about 12% more likely to have experienced overdose. And again, arrest history and felony history remained significant. And African-American clients were about 24% less likely to report overdose relative to their non-Hispanic white peers. And some of that for this population, for our sample, we're starting to put together some theoretical framework with the literatures and looking at the ongoing public health metrics coming out from the CDC. And this could have to do with relationship to fentanyl, potentially, because the majority of our overdoses right now in the US have to do with fentanyl. And given that our population for African-American folks, they were less likely to report engaging in synthetic opioid use, that might be why this population, this sample was less likely to have experienced overdose for that reason. So we'll run some models to verify if that's accurate. But for those with family drug history, they were 6% more likely to receive, to report overdose. And for those reporting primary and secondary substances versus attachment to just one substance, if they owed legal financial obligations, the way in which we define it with that broader spectrum of owing overdue taxes, owing child support, owing criminal justice, fines and fees, they were about 9% more likely to report polysubstance use relative to their peers who did not report owing money to the government. Homeless folks, people who had experienced homelessness were 14% more likely to report polysubstance use. Eviction again was significant, about 10% more likely to report polysubstance use. And those with felonies, again, more likely. Age was negatively associated with polysubstance use, which is not surprising. Because drug and alcohol use is tied, we know, on population science to age. And for those with ACE scores above a 0, each point increase in ACE score was associated with approximately a 2% increase in the likelihood of polysubstance use. So that ties childhood adversity to riskier drug and alcohol use in adulthood. And then multiple treatment admissions. So when we sat with folks, we asked them, is this your first time receiving addiction treatment? And among those who said, no, I've been here before, this is not my first time. Hispanic white folks were less likely, and African-American folks were less likely to report multiple treatment admissions. And this is in line with some of the theoretical frameworks surrounding racial inequalities and access to services for people who use drugs, in network analysis, looking at things like how do you find out about treatment opportunities? How do you enroll in a drug court or sobriety court? There's a lot of institutional racial disparities there, so it's not surprising that we're seeing perhaps a lower rate of access among this population. And so we conclude that these mechanisms are complicated, they're complex, and definitely warrant further investigation because our study does not look at the temporal arrangement of like, when was your eviction relative to when your felony was, for instance. Like, we can't necessarily lay it out throughout their life course. We do have some childhood questionnaires relative to adult current and historic analyses, but in terms of really putting together, what's the chicken or the egg, we can't fully understand. We can basically suggest that there's correlations that warrant further investigation. These are highly problematic, and we believe that individuals who are in addiction treatment, who have limited economic means, require both civil and criminal justice supportive services. And this should be given early in the treatment process before individuals start falling off and needing treatment. So, in conclusion, these transitions can significantly correlate with turning points such as polysubstance use or overdose and return to addiction treatment. So for people who use drugs, getting into treatment can be a pivotal life course shift where individuals then move on to abstain from substances. Now, if that same individual is not able to maintain treatment because, for instance, they're incarcerated on a warrant, that could be a turning point that could correlate with an overdose, for instance. We see very high rates of lethal overdose coming out of incarceration for people who use drugs. So that's one of the outcomes here, and definitely more research to come. And I'd love to hear your thoughts. I'll leave it there. We can skip the research question. Thank you.
We have a few minutes for questions.
Yes, can you tell us a little bit about more about the treatment centers, like, are they sort of private, non-profit, private and for-profit agencies? I know much more about the system, about the providers in Ohio, but I don't know if there's this.
There's two nonprofit treatment centers, according to their public history. So I won't be revealing anybody's business. They were both founded by people who use drugs who are now in recovery. And one was founded by a woman, one was founded by a man. They are similar in a lot of ways, but also fairly different. So one of the agencies is supportive of MAT treatment, so medically assisted treatment. The other one is more abstinence-based focused. So those are definitely going to be things that we control for in our later subsequent analysis. The agencies serve pretty much everyone in that region of Southeast Michigan who cannot afford to pay, who are engaged in treatment. So of course you have to take the first step that you agree to be in treatment. Some individuals receive treatment as a alternative to incarceration. So whether that's part of their drug court or sobriety court. So for those individuals, it may not have been their decision to go, but it has to be their decision to stay. And they understand that if they don't stay, they will be incarcerated. So it's interesting. So some people enroll in the treatment center. A lot of people are referred by various social service agencies and court systems. So it could be someone who's going through a divorce, and it could be, for instance, someone at the family court or the friend of the court, which is the child support enforcement, who connects the individual with the treatment center. So it might be part of a broader social service plan. And many people volunteer at these two agencies. Like I said, that they have limited means, they're nonprofit. What they do with a very small budget is pretty miraculous. I follow their annual reports, and they're helping a lot of people. And there's always more people, so there's a waiting list. Does that answer your question?
Yeah. No, yes, I could ask lots of questions.
I was wondering, at the conclusion that something is very complex in social reality is something I could expect. You mentioned correlations. I don't think causal analysis will help us all that much. I doubt whether we can do that when it comes to social reality. However, with your research, which of the outcomes or which of your findings is unexpected?
The rate of homelessness is very high, particularly among a largely college educated population. So this is something that I don't think receives enough federal attention because the overdose crisis costs estimated, trillion, something $1.5 trillion. So given how costly this is for the nation, for the government, there's a lot of focus on dealing with overprescribing, for instance, and dealing with the medicinal end of the opioid crisis and the overdose crisis, or dealing with drug markets and the supply chain from Mexico, the supply chain from China, for instance, but we're not talking about housing much, at all. And so once you add the housing metric into the major barriers for people once they've entered treatment, everyone I spoke with when I was sitting with the 401 clients, they were all sober. So they were all sort of on the path to maintaining and immersing back into the economy, getting housed, getting a job, going to see their family once again. But without housing, we know that if they exit treatment and there's no housing in place, the likelihood of them using drugs again is quite high. So I think that's something that was, while not entirely unexpected, it was a much higher rate of risk than we anticipated.
Thanks.
Yes.
Your definition of involvement in the criminal justice system was very broad. Do you have a sense of what fraction of those involvements had to do with drug crimes?
That's a really good question. There is some narrative that we have, qualitative narrative responses that we have not coded yet, that have some information people shared with us about their specific scenarios. We did not ask, given the high rates of criminal justice involvement, the survey would have been significantly longer if we had asked specific questions about drug crimes. I think that's an excellent question, and I'd say maybe an omission, like we could have improved the study, but we also were working with a population who is in 24-hour-a-day sort of regimented treatment. And so we had very narrow amounts of time to sit with them, and I had so many questions. So that would be really helpful to know. I can tell you that we do have goals of connecting administrative data from the State Court Administrative Office with our client responses. And so in that case, we will be pulling subsequent criminal activity for up to 10 years and matching them with our client data.
Thanks.
Thank you.
Any more questions? All right, if not, we'll give you a round of applause and then she'll be meeting with all the students afterwards.